You can begin now, Dr. Nagwa. Dr. Nagwa. Oh, okay.
Hello.
Dr. Nagwa. Hello.
Yeah.
Hello.
Yeah.
All right.
So because my mic was muted from your side.
Okay. It sounds good here. You can begin your comments anytime.
So I will start now.
Yes.
Without camera.
Yes. Yes.
Okay. Great. So good evening. Good morning. Hello, everybody. Today I will be moderating with you this session over 1 hour. I'm Dr. Nagwa Khamis. And today the session will be under the title of infection control across borders. It's a very interesting subject. So stay with us and you will see this presentation over 5 sections. The first one will explain the situation of the refugee in our country, Egypt. And then we will go through the health systems in source countries and how to do the risk analysis. And then the third section will present the priority of infectious diseases threats like poliomyelitis, cholera, measles, tuberculosis, and of course the antimicrobial resistant organisms and the vector-borne infections. Then the fourth one will be infection control at the borders, which is the core of our subject today, and how it is a public health emergency that needs an international action and concern. And the fifth section will show how would be the policy, the governance, and the recommendations you are going to go after covering all these 5 sections. Our speaker today is Dr. Gehan Fahmy. Dr. Gehan is a professor of clinical microbiology at Ain Shams University. She is consultant and director of the IPC unit at Ain Shams University Specialized Hospital and Air Force Hospitals. She is a board member of the International Federation of Infection Control for IMRO region, and she is the president of Egyptian Society of Sterilization Practice and secretary of Society of Practitioners of Infection Control of Egypt, and she is a member of Egypt National Health Council. Gehan, the floor is yours, and may I express my interest in your very important presentation and tell you that your cover slide is very inspiring as well. The floor is yours, Gehan. Please go.
Thank you, Nagwa, for introducing me and taking this of your time. Thank you, Bull, and a very warm hello to everyone joining from across the globe. I'm Dr. Gehan Fahmy, a professor of clinical microbiology and infection control consultant Throughout my career, I have seen that infections do not carry passport and they do not respect geographical borders. Whatever it is, the spread of resistant microorganisms or emerging threats. Our fight is a collective one. I'm here today to share with you my 25 years of continuous IPC consulting. I do not just study infection control, I lived it day by day. I would like to explore how we can standardize our defense strategy globally. I'm truly delighted to be part of this discussion on infection control cross border because I believe that in our interconnected world, a pathogen anywhere is a threat everywhere. I want to thank Paul for creating this platform where we can collectively strengthen that global defense. And I'm looking forward to sharing perspective with you all. Thank you for having me. Pathogens do not respect border, but does respect good infection control. In our region, especially in Egypt, when we have a 1 million UN registered refugee and more than 9 million registered by our local health authority, with adjacent 3 collapsing healthcare system, 3 active diseases outbreak coverage, infection control is no longer on the hospital discipline alone, but it is a frontline national security tool. I'm going to try to discuss with you how you can understand the current situation in Egypt, and if any of your countries is having a conflict zone nearby, how to identify the priority of infectious threats, and applying the 3-tier infection control framework created by WHO as international health regulation in 2005, implementation of vaccination, and how do we translate this into evidence for practical guideline. The refugee situation in Egypt is very characteristic. We are in an area, we have a conflict in the 3 borders. On west side in Libya, in east side in Gaza, in southern border in Sudan, with 2 not adjacent but nearby, Syria and Yemen. We also receive refugees for the past 5 years. So we have 9 million refugees. We call it, we host them, not calling them refugee. It is almost 9% of our country population. So it's a very risky situation, leading to more than one challenge, and we should have recommendations. So the southern borders in Sudan is the most important risk right now. But in March 2025, WHO said that we have more than 53 nationalities in our country. We have 76% of them is coming from the southern border in Sudan, and more than 400 every day receiving from southern border and from Gaza. The current situation, most right now, because I'm going to share this slide, 5 years ago, Syrian and Yemen was the outmost important refugee in our country. But now, the eastern border from Gaza and southern border from Sudan carrying the most important risk and challenges coming to our country. So the ripple effect from border to community is very important because disease do not respect border. Also through contamination of spread through water system and pathogens in crowded shelters and vulnerable population which carry infection into our community, making IBC a shared responsibility everywhere. In our border state, like Greater Cairo, Alexandria, Aswan, and border crossing in Rafah and Arish, Egypt have no formal camp. So we don't have formal camp. They living among us in urban city, which is also a great risk. I want to discuss with you like a case report or what we have planned in recent Gaza conflict. In the past 2 years, we created a model for patient flow process from the treating physician in Gaza to the WHO ambulatory care or ambulatory buses to our ambulatory and ambulance in the Egyptian borders. And we make a 150 hostel standby for refugees coming from Gaza. When when we try to manage this problem, our first management was to do mapping or healthcare systems source of the country, risk analysis of the country, which was the source of our refugee. So from coming from Sudan in the southern border, we have a healthcare that is collapsed from more than 3 years. And in early 2025, cholera outbreak in Khartoum state was reported, and it is worsening, giving an alarming sign. So cholera and conflict is initiated a public health preparedness in our country. It is not just by people, it is by underground water as well. So we have a contaminated underground water with inadequate sanitation facility becoming a breeding ground for cholera outbreak. If we study the situation of immunization in Sudan, pre-war it was 85%, but it decreased up to 30% right now. In Libya, in the western border, we have a fragmented healthcare system with many systems inside this country during the conflict zone, and it's not carrying their function properly. This makes WHO declare that cholera and polio are very high. They have only 3 vaccination centers, so we need to make sure that cholera and polio does not cross borders. The main 5 pillar for prevention of cholera, we try to manage this situation because WHO declares that every person should have 7.5 liter per day. But in this conflict zone like Darfur, Southern Sudan, Northern Sudan, not more than 3 liters per day. So what we have to do is to make sure that every refugee have a safe water, a good sanitation, a good infection control, hand hygiene, and we provide them with oral cholera vaccine and oral rehydration pillars. In our southern border, in Aswan state, our local health authority tried to manage a strength of wash, ensuring access to clean water, sanitation, and decrease the use or maybe halt the use for underground water, early detection in the community by symptoms, and preparing our training healthcare system with oral rehydration and planning for vaccination campaign, together with surveillance for communicable disease in the community. In Gaza, which is a very, very difficult situation. In Gaza, only 18% of their hospital is still working. More than 300 cases of acute respiratory infection, and more than 200,000 cases of acute watery diarrhea, more than 75,000 of skin diseases like scabies and lice, and more than 40,000 cases of hepatitis A, plus 135 cases of meningococcal meningitis, more than 6,000 cases of chickenpox, and more than 8,000 cases of acute jaundice. Could you imagine these challenges? It is across border, and we're receiving refugees from this area every day. So this makes us 150 hospital standing by for emergencies for refugees coming from Gaza. After we're doing this mapping for the country we receive refugees from, now we have to prioritize our infectious disease threats. By doing threat matrix of the sourced country mapping, we discovered that the main interest of infectious disease is cholera, polio, HIV, malaria, tuberculosis, and multi-drug resistant bacteria. With multiple route transmission, it may be fecal-oral, contamination of water and food, bloodborne, sexual, vector-borne, blood transfusion, and airborne. So we have these threats with multiple routes of transmission. Number one risk is the polio, because in Egypt, we are a country free from polio. But we start to discover circulating driven polio type 2 coming from Gaza. Number two risk is the outbreak of cholera, and it is rising till now coming from Sudan. Number three risk is tuberculosis. We are a very low incidence of TB because we are mandating TB vaccination since born. But in our southern state in Aswan, which is adjacent to Sudan, we have a high percentage of tuberculosis, 10 to 12%. We also afraid very much from drug-resistant tuberculosis because the program of treatment is interrupted in Sudan. So we created an Aswan Chest Hospital acting as a principal referral hospital for local health authority. Then malaria. We don't have the vector in Egypt, but it is endemic in Sudan. And unfortunately, we discover a nosocomial transmission via blood transfusion, which make our local health Ministry of Health mandated a blood safety program. We don't usually scan our blood bags for parasites, but now it is among the strict protocol to screen all blood donation for malaria. And for all patients, new admission to our hospital, parasitological confirmation by microscopy and rapid test is mandated. HIV, a major risk, can cross border, it is driven by transmission by human mobility. And it is identified and diagnosed by molecular epidemiology, tracing the viral genetic, show persistent bidirectional cross-border HIV transmission, proven by virus move with people regardless of official border side, and it is mainly from the west side, from the west border through Libya. At the border, there is a compound risk, increasing the storm for HIV vulnerability. There is a mobile group at our border or at any border, mobile group including refugee, displaced person, truck driver, migrant worker who may be separated from the usual healthcare system. Also, in here I can say that Libya received refugees also from Darfur and South Sudan. So we have a mobile group coming from Sudan to Libya with a fragmented healthcare system and disrupted service in this conflict area where the war is going on right now. It destroys the healthcare system, halting the HIV testing, treatment program, and prevention service. And at the border, people face fragmented care stigma, fear of deportation, language issue, and lack of insurance. There is escalating cases in Libya of HIV and hepatitis C with this compounding risk factor I have just said. This is acute challenge. Number 6 risk is antimicrobial resistance, which is a major risk in all over the world, but we discover it when we do a swabbing for wound war coming from Gaza. We discover there is an increased number of multi-drug resistant bacteria, especially MRSA, extended spectrum beta-lactamases, Acinetobacter, and carbaminoase resistant strain. When we discover that the Egyptian hospital, which is standing by for refugees coming from Gaza, start to do a program for early detection and the treatment of multi-drug resistant bacteria. We ensure that there is a pre-admission screening swab, nasal for MRSA and rectal for carbaminoase resistant strain and extended spectrum beta-lactamases, with a detection, with a dedicated room for isolation and cohorting not by nationality but by pathogen, starting the empirical antibiotic, keeping in mind that maybe there is MRSA and ESPL or CARBA, and reviewing the antimicrobial stewardship monthly. We try to make sure that every hospital of the hospital receiving this refugee can have a microbiological lab with a rapid susceptibility testing or a referral lab standing by. Now, after we do the mapping for the sourced country and prioritizing our risk, trying to implement the international health regulation, which is founded by WHO in 2005. It is lie mainly on three concentric tiers. Tier 1 at the point of entry regarding quarantine and vaccination. Tier 2 inside the hospital when triaging, cohorting, personal protective equipment, and antimicrobial screening. And tier 3 is at the community, which is communicable disease surveillance and isolation and cohorting by symptoms. The international health regulation done or applied at international airport, port, ground crossing, and we increase and maintain our core capacity at all the time. Mainly coordination between all the authority, public health, WHO, our local Ministry of Health, the High Supreme Council, Immigrant Civil Aviation. This coordination is very important for record keeping and for information. With rising all the capacity of our routine capacity from trained personnel, designated facilities, transport, equipment, communication, which is mainly specific for refugees. Increasing our public health emergency also from isolation, contact tracing, vaccination, decontamination program, and vector control. And the most important thing is information and documentation and record keeping. The international health recommendation make an IPC package, which is a very important package. You can apply at any border with any situation, especially when there is a conflict zone, and unfortunately the conflict zone is everywhere right now. This IPC package is synthesized by WHO, CDC, European CDC, International Organization of Migration. It includes, and it is applied in our border state, Cairo, Rafah, Aswan, Alexandria. Mainly, it includes triaging by symptoms like fever, respiratory infection, rash, diarrhea, jaundice, and wound. Second, vaccination. Especially look for vaccination history, which is the yellow card. Early warning, alert, and response symptoms. That is to say, syndromic case definition. Dedicated isolation room at every point of entry. Standard personal protective equipment stockpiles is present, including N95 mask, especially for suspected TB or measles. A link between fever hospital, Ministry of Health, and local authority. Confidential, volunteering, non-discriminative communication, and never restart a vaccination program, but only continue from where it stopped. The vaccination program is very important. Start by looking for document for vaccination, which is the yellow card. Establish a vaccination station at each border or border crossing. Routine vaccination immediately when there is a lack of documentation, and refer to the local authority for multiple doses of vaccination. And I'm here proud to share with you our experience with Gaza polio campaign we did in 2024. We negotiate a 9-hour humanitarian pause when we start to supply a mobile cold chain in shelter and tent. 700 vaccination team is available with 700 social mobile sealers and 2,700 healthcare workers. In 2 rounds, we managed to vaccinate more than 600,000 children in this campaign for polio and measles. We achieved, despite 90% energy collapse, mass displacement, and active combat. I think it is a very successful model we done in Gaza to manage the collapse of healthcare system. But we face many challenges and barriers like funding, language and culture, documentation, our healthcare worker are burned out, and some political sensitivities. Now to the most important one is the hospital IBC. Hospital are the first line of detection and last line of defense. We must be prepared to handle both sporadic imported cases from neighboring crises from Sudan, Gaza, and Libya, and the ongoing burden of our endemic diseases. And the endemic diseases like malaria coming from Sudan. A single missed case of viral hemorrhagic fever or extensive drug-resistant tuberculosis from conflict zone can lead to a devastating hospital outbreak if IBC fail. So we managed to create a special policy for refugees in hospitals. This final policy is for cross-border infections, is written, practiced, audited, and funded, and have a core. It's now one of our core component of national health security because there are 9 million, more than 9% of our population is refugees. This policy lies mainly on 3 aspects. Number 1 aspect is triaging and early detection. Identify and isolate potential cases at the earliest point of contact. In the front of the house, it is in the ER or outpatient clinics. We should ask mainly for traveling history in the last 30 days, especially for Egypt, which current situation I'm talking about, to ask about traveling history from Sudan, Libya, and Gaza and Yemen in the last 21 days. Also ask about occupation. Are you an aid worker, driver? And asking, very important, about fever, symptoms like fever, rash, acute watery diarrhea. We use a visual alert signs, which is a clear signs in multiple language instructing patient with fever or relevant traveling history to alert our staff immediately. Starting rapid isolation, which is a policy for immediate isolation of suspected high consequency infection, viral hemorrhagic fever, cholera, MERS-CoV in pre-identified isolation room or area. Number 2 is the main infection control preventive measure in this policy is to apply correct type of isolation based on disease transmission. Contact precaution, droplet precaution, or airborne precaution according to the disease in the affected refugees. Thirdly, how to protect our healthcare worker, which is already overwhelmed and already burned from a lot of worker, by protecting them by vaccination of healthcare worker, should fully vaccinated, especially for influenza, hepatitis B, measles, and COVID-19. Always do a drill for upcoming refugees if they coming in great numbers. So a continuous drill for infectious disease is very important. And to ensure post-exposure prophylaxis, especially after needle stick injury or splash to a mucous membrane from blood-borne pathogen like HIV and hepatitis B or C. When we finish from all these criteria, we give our government and local health authority a strict recommendation. We recommended that the border state, we should increase our mobile phone coverage, and we make a strict recommendation for our local health authority to provide a basic emergency service free, and the free TB and HIV treatment. Together, we make this refugee, maybe they are not ruled out in our healthcare system, but a feasibility study to ensure they underway on inclusion of this refugee in our healthcare system. Coordination structure was performed between all WHO, UNICEF, Egyptian Red Cross and local health authority to have a correct number and knowledge about the pattern of infection coming to our country and for record keeping. Our recommendation today may be to all IPC in our country, mainly to the frontline healthcare worker, always ask, where did this patient come from in the last 30 years, 30 days? Use a structure or liver checklist. Having a vaccination card, fever, cough, rash, jaundice, wound, and last menstrual period. Use language interpreter in person or via phone. Always assume there is a multi-drug resistant organism in the war wound patient, especially from Gaza and Sudan. Vaccination is very important at every clinical contact. Document. Incomplete record are a public health failure. And for hostel team, establish a refugee medical IPC SOP aligned with IFIC basic concept of infection control, cohorting by symptoms, pre-admission screening for multi-drug resistant bacteria, monthly antibiogram review, and currently hand hygiene compliance audit is very important. Usually stockpiling the personal protective equipment with mask of N95. For public health policy, we recommend to our local health authority to expand the mobile coverage in our border state, because communication is very important. Now, let's bring this home to us. It is one size fit all the process. IPC preparedness can fit in any country which nearby conflict zone and receiving refugee. The fundamental takeaway message I need to give it to you: we don't need to be separate to have a separate plan for every disease. We need a single stepwise scalpel roadmap. This roadmap is very important. Here we are facing whatever you are facing: Ebola, novel influenza, any disease X. The pillar remains the same. The IPC pillar remains the same: early detection by surveillance at point of entry, rapid isolation, immediate protocol, and safe surgery capacity, training staff to scale up without breaking. Egypt geographically is at cross board of continent and travel. By standardizing the core IPC roadmap, we ensure that regardless of where the next threat originates, our response is swift, coordinated, and effective. We must shift our focus from waiting for specific event to strengthen our system. In closure, I want to leave you with this. We need to establish a standard stepwise roadmap, playing in how to identify the risk and how we do protect our staff and how we do contain the spread. If we have this roadmap firmly in place, we don't need to panic. We don't need to guess. We simply need to execute. By doing this, we turn our geographic position from vulnerability into strength, ensuring that Egypt is ready for any threats at any time. Thank you very much for having me, to make me explain to you how to use this IPC package and how we do our checklist and how we do our roadmap. Thank you very much for having me. For you, Dr. Nagwa.
Thank you very much, Gehan. Thank you very much, Dr. Gehan. Really, it's a very informative presentation. You are presenting a very sensitive and risk subject. The example how we dealt with this problem with all these challenges we faced during the last 2 years at least, and how we could contain some of these risks. Um, Now I have few questions for you, um, just to highlight again some points you discussed already or you presented already in your presentation. Um, what would be the main action of international health regulations? Because this point is very important.
Narrated by WHO 2005 is mainly on three concentric tires. One at the entry point, and one is the hostile IBC from triaging, cohering personal protective equipment and looking for antimicrobial resistance, and in the community for surveys of communicable disease by symptoms. So it's mainly lie on three concentric tires.
Okay. Here there is a point, if we go to the point of um, the IPC package at the point of entry. But
Yes,
we should put into brackets, provided the point of entry is the official one. Because as you know, we got many refugees via non-official routes. So at least at the point of entry, the official one, what would be the IPC package? Because I believe um, the official point of entry, if we can manage refugee in this part, of course, we will cover a good portion or proportion of refugees totally. So tell us about the package at the point of entry.
uh, our IPC package at point of entry lie mainly on triaging, vaccination, syndromic case definition, early detection, and isolation of IPC point, as you have just said, in a legal cross-border meeting
Yeah.
from at airport and our ports. Yes.
Okay. Yeah. Uh, the next question is a bit not a dogmatic one. So, what was your thoughts while formulating the philosophy behind this title, IPC across borders?
Mainly, microorganism does not respect borders. It doesn't
Yeah.
simply it doesn't respect any border. So eh, our geographic position across continent make us has to have a roadmap firmly placed because we don't need to panic. We need to be ready at any time.
And if you let me tell you about my impression when I read the title, that between lines, it might mean also that microorganisms respect us as IPC
Yes,
professionals.
yes,
So I
yes,
felt delighted with this presentation, especially when you said that they don't respect borders, but they do respect IPC and IPC professionals, of course.
yes.
Um, my last question is, give us the most concise and effective home message, please.
As a part of our globe, I'm proud to say that Egypt show a very humanitarian and effective example of preventing infection in the middle of crazy world for of infodemics as well. So we did, I think we did our job in a very humanitarian and great IBC way.
So this is your concise message, is to take what Egypt did regarding this issue like a role model, and to try to follow the steps so we can contain any threat of infections across the world borders. Thank you, Gehan, again, and thank you
Thank you, Nagwa.
for your presentation, for the details you presented.
Thank you.
Let me now remind you with the next webinar sessions of International Federation of Infection Control, joined with Paul Weber teleclasses. So along September, we will have one session or one webinar, 15th of September from 2:30 p.m. till 3:30 p.m. Geneva time. It will be under the title of Understanding the Role of IPC in the Planetary Health Landscape. So I'm interested to attend this session to know how are we going to do this in the planetary level. The speaker will be Professor Dr. Walter Zing and Dr. Ermira Tartari. Then on Thursday, 29th of October at 1:30 to 2:30 p.m. New York time. The teleclass will be under the title of Leveraging Artificial Intelligence to Transform IPC, Evidence, Barriers, and a Practical Decision Support Framework. The speaker will be Silvana Gastaldi and Dr. Ermira Tartari and Giovanni Sata. On Tuesday in November, we will have the 17th from 2:30 to 3:30 p.m. Geneva time. We will have a storytelling and healthcare associated infection prevention. This will be very interesting too. The speaker is Amanda Maciel from Sao Paulo, Brazil.
Thank you very much, Dr. Nagwa. Please, this is Paul Weber speaking. For those of you who are not yet members of the International Federation of Infection Control, please do make a point of joining. There are some teleclasses in the Weber training session scheduled for August, and they're listed here. You can see them on the website. And finally, thank you to our patron sponsors, Diversey, Virox, and the International Federation of Infection Control for making teleclass education possible. Thank you again to everybody, and we'll speak to you again soon.